Welcome to the second episode of RenéMarie Stroke of Luck podcast and TV show, I should say. This is going to be an extraordinary show. Sophia Lopes is that how you say your name, Sophia Lopes?
Lopes, close enough, but yes.
Sophia Lopes is our special guest today. Of course, we got introduced from Diane Bromberg was the tech connection for that. Diane is on our board. She does an extraordinary job with us. Really, she's a connecting whiz, Diane. So she does a wonderful job. Ralph is here for the second show. He's the Stroke Warrior Radio founder, and we'll hear a little bit more from Ralph as well. Ralph is really a gift to our organization. He's part of our family. So thank you, Ralph, for everything you do for us. We want to just acknowledge once again our heartfelt condolences to Jim and his family and his wonderful family, Jennifer and Josephine. I'm seeing a rainbow in my eyes when I close it. Josephine and his other children and his grandchildren. We really want to share our heartfelt condolences. Jim left far too soon, but the gift, if there is a gift, is that he's not in any more pain. He was in pain for all the years that I've known Jim. So you got to find light at the end of the tunnel. So we really just wanted to share that with everybody. So this show is going to be extraordinary because Sophia Lopes has really a passion for clinical trials, and we really want to find out what is in the forecast. Let me read her bio. Sophia Lopes, MS, holds a master's degree in psychology from Drexel University and a bachelor degree from Kean University. Actually, my mom was a master, what do you call a teacher there? I'm forgetting. Yeah, she was a teacher there for music. She at Kean University. I've been to Kean University. It's beautiful. She has over 3 years experience in the field of tell me with that, Sophia,
Neuropsychology,
administering cognitive and clinical scales to adult and genetic patients with neurological compress in both research and clinical setting. Far too detailed for me because I am not medical at all, but we are so honored and privileged to have Sophia here, and Ralph is gonna ask some questions as well. Let me finish by saying she is dedicated to contributing to the breadth of knowledge in the dementia community, specifically in clinical trials. She is committed to providing valuable support for those experiencing cognitive challenges and ways to maximize brain health. Sophia is enthused for the opportunity to apply her skills and passion to her role at the CRCNJ, which is, let me just see, let me just read. My thing is my. What's the CRCNJ stand for, Sophia?
the Cognitive and Research Center, New Jersey.
Wow, it's pretty impressive. And Ralph and I were talking about before how impressed and how knowledgeable you and your medical field are. Really impress us with your education. It's really, so welcome to the show. We're really happy to have you.
Thank you so much. Likewise, I'm really excited to be here.
So Ralph, do you want to ask the first question? Why don't you ask Sophia how she
actually I would. A master's degree in psychology, how did that develop into, well, and let me tell you why I'm asking this.
Sure.
I didn't realize after my stroke, for example, that there was a difference between a physical therapist and a neurophysical therapist. And I didn't realize there was a difference between psychology and neuropsychology. What particularly inspires you to specialize in that?
Yeah, I've always had an interest in psychology. I've always wondered, why are people the way we are? We're so distinct, yet we have so many similarities as well when we kind of peel back the layers. And it started off very broad with psychology, right? There's so much that's within psychology. There's neuropsychology, there's forensic psychology, kind of so many avenues to go within that. And I really got fascinated with the brain. It's like our master organ for our body, and it has 80 billion neurons or something like that. So
Wow.
It's very complex. We think we know a lot about the brain, but really there's so much that is yet to be researched and yet to be learned about. So I think that that's what's really fascinating to me, is that there are so many advances and we're learning more about it. And it kind of rules everything about us. So neuropsychology is a branch of psychology, underneath that umbrella that examines brain behavior relationships. Even within neuropsychology, there's still so much kind of legs within it. So particularly my interest, is more so traumatic brain injury and Alzheimer's disease, these ailments that are pretty substantial to our function.
Oh, okay. What kind of critical cognitive assessments do you use to evaluate stroke patients and TBI in particular?
Yeah, that's a great question. So I worked, as you know, for I think 3 years of clinical work, 3 years approximately in research. So I have a little bit of understanding in both areas. I worked under neuropsychologists to administer cognitive testing. So it can vary depending on the referral question. For example, if someone comes in for a neuropsychological evaluation that their neurologist ordered, it's to answer a question. Can this person who had a stroke event last year return to work, right? So we examine in those testing, we examine different areas of brain functioning and what is really impacted and how that could translate to their job performance, for example. So it depends. The neuropsychologist selects those tests, but they're all validated instruments to test particular areas of brain functioning, like how well can you picture name, what is your IQ, what is still reserved from this impact to the brain, and what is impaired, and what does that mean for your daily life, for your function. So there's a lot of things to unfold within there. But for now, since I'm more in the Alzheimer's community, I focus on measures that the funding sponsor of a particular clinical trial identifies for us for that particular study, to see, their function and get more information about that.
I have a question. I'm because with stroke patients, we could recover a little bit, right?
Mm-hmm.
We could with dementia. Is there any possibility for recovery, or is that really a diagnosis that with time gets more complicated?
Yeah. I think more so the latter. It's characterized by these abnormal proteins that develop. So it's called amyloid plaque and tau tangles, and it's within the cell neuron. So it's kind of like compensatory strategies and life factors, things that we can do to prevent the onset or slow down the progression or manage the behavioral manifestation of this disease. But unfortunately, as we know, there's no cure. There's no PT unless it goes to functional impairments. But that's when it gets quite severe. So there's things that you can do to manage or prevent the onset. But again, there's no cure. Does that answer?
And what are some of the things you could do to prevent the onset of dementia?
Yeah, there's 8 pillars that I can touch on. So this is to improve your overall brain health and cognition. So this is for, making sure that we are physically active, right? Physical activity is really important. Social stimulation, engaging yourself in conversations where you're constantly learning, kind of staying away from sedentary activities such as just watching TV all day and sitting there. You want to make sure that you're teaching the brain new things and keeping active. So that's just 1 or 2 of the things. Of course, there's other things, right? We hear it from doctors all the time on how to improve our health, but we don't really think about our brain really, and that masters everything else. So another one is adequate sleep. This has been shown in research to have a high correlation with dementia, just because 7 to 9 hours is recommended per night. And with those abnormal proteins that develop, we can brush away those toxins in our sleep, in our restorative stage of sleep. So phase 4, it's called rapid eye movement stage. I'm sure we have heard of it, but it's like the dreaming state. So it's where we wipe away those toxins that can accumulate during the day. And, you know, Alzheimer's disease accounts for 60 to 80 of dementia cases. So it's pretty common, and it's just going to increase in terms of numbers. So that's why research is really important as well. Another thing I want to point out in terms of risk factors is cardiovascular risk. So making sure that, you know, if there is any circulatory issues or heart conditions, that we have that managed via medication or following up with our doctors accordingly to make sure that we're in the best shape that we can be. So as we age, there's this age-related cognitive decline, right? After 25, really, it's you know, you have some memory lapses and cognitive lapses, and you're not the same.
Feel normal now.
You know, we're not the same as what we were a few years ago, and that's fair to say, and that's in fact expected. You know, you walk into a room, you're not sure why you're there. Where are my keys? I think as long as it comes back to you, you're in, you know, it's fine. But now if it becomes a big change to your functional activities, right? If it's uncharacteristic of you, if you're forgetting things rapidly or not, you know, it's not coming back to you, that type of information. Now that's where it becomes concerning, right? Is this age-related cognitive decline, or is there something else going on beneath the surface that is disease causing? And that's where it's hard to kind of draw the line. That's where these cognitive testings comes in, and you know, to get more of an idea of what's going on and what's causing that.
What examples do you have of those cognitive testing that people might?
Yeah. So for a regular neurologic workup, say you go to the neurologist and you present with memory impairment or memory concern, they might do a mini mental status exam. So it's called MMSE. I do these in my sleep. I do this so many times. I think it's the most widely used instrument in neurology and neuropsychology. It's a very brief cognitive screener. So that's just to test for any cognitive compromise or cognitive concerns, whether it's normal or mild cognitive impairment or something more severe. And it's like an indicator of whether this deserves more thorough workup. So it asks you orientation questions, you know, what day is it? Do you know where you are? What state are we in? Those are just some of the items. And then following simple instruction, can you fold this piece of paper and put it on the floor after I give you the instruction once? Can you repeat after me? When I say a sentence, one of the sentences is no ifs, ands, or buts. And you'd be surprised, you know, I get different responses for that as well, just depending on the impairment. And then you get a score. So it's out of 30 points. 27 or up is indicative of like normal functioning. Anything below that, you know, not too concerned, but it depends. I've seen in the 20s being like, you know, hey, let's refer you to a neurologist to get this more thoroughly evaluated. Or if it's like 15 to 20, that's more in like the moderate stages. Of course, this is not diagnostic, but it's definitely a validated indicator. And one of the things that they'll do first off the bat to refer you to neuropsychology. If you go to a neuropsychologist, it's more vast, you know, 3-hour workup. I've done those evaluations too. It can be a little bit tiring for the patient though. So one of the things. Another one is they do dementia or Alzheimer's specific exams. So one that I do often is the CDR. So that's the Clinical Dementia Rating Scale. And it's a semi-structured interview. So you sit down with the patient and you sit down with the patient's proxy. It's like a family member, close close friend, etc. Just someone who knows them well and can answer questions about their functioning. Because sometimes you'll have the patient underreport, and then the close friend or whoever it is will be like, oh no, they actually do XYZ, you know. So that's a more accurate description of, okay, aside from your cognitive impairments, how is this affecting your daily life? You know, are you leaving the stove on? Is this danger to yourself, independently living? So it tells you much more information, aside from just what's written on that test. You can ask them other questions as well that are not there that may give you more information in terms of clinical manifestation.
Is there any electronic testing at all these days, or is it, I mean, technology, the advances, I mean, they're amazing. Do you have more of that you're using in clinical trials or research?
Not electronically. You'd be surprised. Majority of my test administration has been paper pencil. I prefer it that way, surprisingly, in terms of giving these tests, but it would be down the line much easier if we do transfer them electronically, although I worry that some things may be lost, right? There's some behavioral manifestations and cues that are really important for diagnostic workup that might not be caught electronically. But I think in the future, especially in research, we will be implementing more electronic data capturing, if not implemented already. I mean, it does vary from trial to trial. I know there's tests out there that you can access on Google in terms of cognitive testing. I'm just not sure how valid or sensitive they are, considering we're kind of missing out on that motor part, right? You're just kind of clicking buttons or, you know, doing instructions. So they will likely be very quick, maybe executive function tasks, since they tend to go first in dementia.
And what are some of the things that would get lost? You mentioned that there's some specific, I guess, traits or movements that would get lost. What is one or two of those that you think need to be manually done, like that you believe should be manually done?
Oh, and testing. Yeah. I think motor skills are important as well. And like behavioral cues or like social cues kind of get lost, right? So if I say something and they don't have a hearing impairment, right? So this is isolative of a hearing impairment, because hearing impairment's not dementia. So people sometimes, you know, they're like, I have memory loss. Well, are you hearing the information first? Right. That's the first step. So I think that's important, right? If you don't have hearing loss, you know, there's definitely a disconnect there, that they can't gather the instruction. They can't kind of establish set of what to do, or
Excuse me. That's okay. No, have a drink. Have a drink of your.
I'm like choking on nothing.
Okay. We're live. No problem at all.
Sorry about that.
Oh, it's fine.
But yeah, I think that, or in terms of motor skills, like if you're asking them to draw something and they have kind of like a tremor, that's something to consider as well. You know, is Parkinson's disease on the table, or some type of essential tremor that is under Alzheimer's disease pathology. So any information that can be gathered during that testing is going to be really important for the neuropsychologist, because I act as like a data entry, a data gatherer, for the diagnostic workup for the patient. So I give that information to the neuropsychologist, if in a research setting, but mostly in a clinical setting, so that she can gather information and come up with an accurate diagnosis. So any maybe is important.
Maybe they didn't see that prior to it.
Exactly.
Yeah. Ralph, did you want to ask a question?
Yeah, I'm trying to frame this in my mind so it doesn't sound that silly. Clinical trial isn't only testing the effectiveness of treatments, it's also doing the research. It's also a research factor to it, isn't there?
Yeah, absolutely. Clinical trials are investigative, right? So think of it like a research project, but to test the efficacy of a particular drug that is intended to go on market, right? These drugs that are FDA approved and prescribed via your neurologist, they have all undergone a stringent eligibility criteria and milestones within clinical trials, right? So clinical trials are very important because, without participants, we won't be able to carry out this study to further investigate, whether this drug is effective or not in trying to slow down memory progress. Yeah, so it's research. It's to
And
find
that's where
out
your passion,
answers.
and that's where where we were talking on the phone, you were saying that your passion is for these clinical trials, right? Was that because that's the direction that you're really passionate about, to, I guess, to learn new things and to help the brain health stay a little bit better, and to all the time. Talk to us a little bit about that. Why it's one of your passions. Why that's a direction that you
Yeah.
like to go in more.
Yeah, absolutely. There's such a need for it, right? Like I've always wanted to help people, but that's very like, okay, Sophia, let's get more specific.
Yeah.
Um, so I think kind of going into these clinical cases where I've done neuropsychological evaluations for clinical purposes, I have seen a lot of dementia cases and a lot of Alzheimer's cases in specific. So my current job is very niche in that it has to deal with Alzheimer's specific clinical trials, right? And trying to find a cure, because that's going to be the only way that we can find a cure. And I think it's just a great, it's really up my alley. It's a great fit for me because it encompasses all of that. I come from a clinical research background, but specifically in neuro, and that's where I'm at. It's this site nearby that is
Right.
specifically for clinical trials. They no longer do diagnostic workup, so this is not diagnostic, but it doesn't substitute your medical care. So it kind of works as a supplement to your medical care because we talk with neurologists as well to get particular information. So it is something I'm really passionate about because the disease is an ugly manifestation. It affects a lot
Yeah.
of family members and friends,
Yeah.
not only the patient, mostly the patient, but it's just hard to see. And of course, we all know someone who has had Alzheimer's disease, and we were able to see, the physical manifestations and the complications that it poses. So, and unfortunately, we don't have that many answers as we would like. But there are things that we can do to reduce the risk of it, or, there are risk factors like genetic predispositions or environmental stimuli, but those are
Right.
things we cannot control, right? So we got to focus on things that we can control. So I really feel for these people. I'm a very empathetic person, and I think that translates well into this field because people need support, and there's still so many things that are unknown and so many things yet to still learn. And I just want to provide a valuable contribution to advance what we know about dementia research.
Wow, that's
You
very.
mentioned
Ralph, before you ask that question, I just want to, while we were sharing that, I want to know your history. Like, what did you do as a little girl? What led you to this place you are, making a difference in the world? Like, what inspired you? As Ralph and I were talking about before, what
yeah.
inspired?
I think it just started out broad, and then as the years went on, I just kind of led with my heart and where it brought me. I don't have this like one pinpoint aha moment, unfortunately. It kind of just came naturally to me. Um,
which
you
is
know, I
which
think,
is a gift which is a gift
Yeah.
because most people in their lives are like, okay, I have this talent, I have that talent, where do I need to do, what do I need to do with it? And you actually just kind of like went that direction. That's very
yeah.
admirable.
Yeah, I've always, well, you know, as a little girl, now that I think about it, I've always had a knack with older folks for some reason. Like I love kids as well, and I've dabbled in, okay, do I want to pursue working with kids? But when I worked with older adults, it was different to me. Like I
Yeah.
was able to sit and understand or try to understand where they came from. They have so much history, so much like
Wisdom.
information. Exactly. That's what I was
Wisdom.
looking for. Thank you.
Yeah. Wisdom.
So
My
I have,
thank my father, because my father, we used to own a deli in Hawthorne, New Jersey. And my father there was an apartment building next to us, and elderly people lived in it. And he
mm,
used to walk them home, and he used to talk to them. And he always came back and said they have a wealth of wisdom. They have so
yeah,
much that we as young people need to listen to them. We don't need to
absolutely.
follow them so much, but we need to listen because they're sharing important information for us.
Absolutely. And at the end of the day, most of them just want companionship and just want to be heard. And
Yep.
unfortunately, you know, they go to these healthcare settings and some people, you know, are made for the healthcare system and others are not and
Yeah.
don't have that bedside manner that we're looking
Yeah.
for, right?
Yeah.
So it's really important that we try to understand this and not take things personally. You know, for example, if a patient is acting out, right, quote unquote, it's the behavioral indication of the disease, right?
Yeah.
And not
Yeah.
take it personally, because it is, you know, once it gets pretty severe, it can be unpredictable and hard to manage. So it's really important that we strengthen our education surrounding this disease. And, you know, I've understood that when I volunteered in Alzheimer's homes as well as a teenager. So I think that that's what really started it, that I had a lot of questions. I was very curious as to, you know, why does it look different in this person than in this person, right?
Mm.
So that's really interesting to me. But again, there's so much room to learn, and I'm a lifelong learner in
Yeah.
psychology. I really like to learn more. And that's what I like about my job as well, is that you're always learning,
Yeah.
right?
Yeah.
Especially with research, you're always learning. Years ago, we were only able to diagnose Alzheimer's disease post-mortem, but now, you know, we're starting to come up with these blood biomarkers specific to detecting these abnormal proteins too.
Mm.
So it's
Wait, I have a question for you because what are abnormal proteins? What are we talking about when we're talking about proteins? The proteins that make up the brain?
So there are these two proteins I had mentioned. So it's called the tau tangles. So it's like these tangles that develop within the cell neuron. And then there's this amyloid plaque. So the amyloid plaque is outside of the cell neuron and is like a sticky substance that gets in between the neurons so that they can't communicate effectively and quickly as they should in normal aging, for example. So these plaques, they can disrupt memory and functioning due to that loss of communication between cells, and they're abnormal. So I think I read something months ago that we develop amyloid, but we have that flushing system that takes care of that, especially when we sleep. So these toxins are kind of blown away with cerebrospinal fluid anyway. But I don't know what causes a person to have that effective flushing system and not. So that's a good question. There are limitations here because I'm not a physician, but
Hmm.
they're all great questions. So just like you can develop plaque in your heart or in your teeth or in your veins, you can also
Right.
develop it in your brain.
Hmm. So that to me, and I'll let Ralph ask the next question, but to me, if it's something you develop, like with like on your teeth, a plaque, there
Mm-hmm.
are ways to prevent that. So what are the ways to prevent this from happening in the dementia world? I know that that's that's one of your
Mm-hmm.
main questions in your life to find out how to help that.
Yeah,
So
yeah. Um, Again, with this topic, there is
yeah,
not a straightaway answer.
yeah, yeah,
It's going to fall on lifestyle factors.
yeah,
So things like, kind of going back to that physical activity,
yeah,
adequate sleep, healthy diet, Omega-3 fatty acids, Mediterranean diet has been recommended for brain healthy food. How we nourish our body and what we put into it is very important. Relaxation and stress reduction is another one, because we see that in the memory and learning system, which is called the hippocampus, is usually in most cases firstly affected with Alzheimer's disease in terms of where the plaques can accumulate and what it affects first. So that's why we usually see the memory and learning impairments first, but it's like a magnet to these hormones, the stress hormones, which is called cortisol. And that can affect it. Think of things like when you're stressed out, when you're anxious, right? We can't think clearly. Our prefrontal cortex is down, offline, right? And our anxiety is up. And you can't have two things on the table at once. So that's going to be important, right? Reducing stress, risk factor reduction, following up with our doctor, and getting involved in research so that we can get more answers, right? Because this is not a straightaway answer for prevention. It's not a straightaway answer for a cure or for treatment or even diagnosis. There's a few things on the table, but again, it affects everyone differently. So just to keep these in mind.
Well, Ralph and I both know because we both suffered strokes, but they're completely different. Right. They just, every stroke is of a different makeup.
But similar too.
What's that?
But similar too. I mean, there's and which makes me curious in stroke recovery. It took me a number of years after my stroke. I'm 9 years post-stroke now. But it took me a number of years to realize how many therapies there were available to me that they weren't told to me as I was progressing. Which in my mind, I became the captain of my own team. Tell me about the team. You mentioned a neurologist, you mentioned a physician. What does a team look like in clinical research for members of the team that work with you? Yeah,
we have more patient-facing roles versus non-patient facing roles. So as you know, for example, I love working with patients. I always have. I want to make sure that I have opportunities to be in front of the patient and yet work operationally behind the scenes sometimes. So I like a little mix of that dynamic. However, there's a principal investigator for the clinical research, right? So that's kind of the head of the research. They assume all responsibility of the operations of what is going on in that particular trial. However, they also delegate tasks to the team, right? They can't do everything all at once all the time. They're very busy people. So there's also sub-investigators. It can be a medical personnel, just depending. So for example, we work in neurology, so our sub-investigator is a neurologist. And then the primary investigator is a neuropsychologist. But this can vary, there are also cancer clinical trials as well. So that team may look more specific for that particular topic, a cancer team. There are also clinical research coordinators. So they do the daily operations of the clinical trials and managing the study visits. There is my role as well. So I'm the rater and recruitment specialist. So that's rater is just someone who does the clinical testing of the trial and carries them out. And so it's like that data collector piece, right? So we're learning more information about how that person is how their cognition is. So that's just one way to test that, is that cognitive testing. Again, also with the recruitment. So I do both pieces. So I recruit folks, whether it's community events or talks like this sometimes, which I'm training for currently, and print ads, anything that we can recruit these specific population to bring them into our facility to screen for a particular study. But again, clinical trials are all optional as well. So we want to make sure that the safety of the patient is paramount, is our number one priority. And then you have people that are lab techs as well, that mix, process the bloods. I don't know details about that, but process the bloods via like any type of software that they have in the lab room with the test tubes and the pipetting, and they're shipping blood samples out to the lab for testing. So I think it's a very multifaceted approach and a very collaborative team where everyone brings their own personal expertise to help answer a question. And I think it flows very nicely.
And who oversees, like, I know there's different parts, but who is the main person, the neurologist?
Yeah, so in this
gathering all that information?
it does depend, but in this case, it's the neuropsychologist since it's her founding practice. But it can also vary. Yeah, sometimes it's a neurologist that's the primary investigator as well. Just someone who is credentialed to carry out these research tasks and delegate them accordingly.
Right. And
Yeah.
What do you say is what do you say is the biggest challenge in neuropsychology today?
I think it's these questions, like answering these questions, because it can be frustrating, right, to not have an answer. And it's something that we're aiming to answer through our research and through these investigative studies, right? So I think that that's what's it. And it's the hard part because, like, we want answers. We want straight away answers, but it's a very muddy waters, and that can be frustrating for not only the patient, but also for those who are passionate about getting these answers and the workers, right?
Yeah.
And the families. And the families.
Yes, and the families as well. That's a good point.
The families
To follow up on that, what's the most promising developments in neuroimaging and cognitive rehab that excite you the most right now?
This blood biomarker test that I had mentioned. So it's not FDA approved. It's probably something I will assume you haven't heard of because it's very new. And it's a blood test that we actually do on site. Our site staff does and other sites as well. It's called the p-tau blood biomarker. So it's a phosphorylated tau. I know it's a big word. Phosphorylated tau. To detect those abnormal proteins in the blood. So there's a way that, lab technicians can separate the plasma with the blood cells and detect that specifically. So I think that there's some promise there. Not FDA approved yet, but hopefully in the future, and this can give us, some cushion room in kind of getting the answers that we're looking for in terms of detecting this earlier on. And we're also looking to identify these folks earlier on in the disease manifestations so that we can intervene earlier on. And perhaps with this, that we can develop a cure with Alzheimer's. We can have these medications on the market that will just, be a cure, hopefully, in the future.
Is it hereditary?
There's this apolipoprotein 4. It's called APO4. That indicates higher risk and is genetic as well. But it's weird because just because you do have that protein doesn't mean that you'll get Alzheimer's disease 100%. So that's another frustrating thing is like, yes, there's a lot of things that can point to higher risk of getting the disease, but it doesn't necessarily mean you'll get it. But it's definitely higher risk. It's not correlative, is that the word I'm looking for? It doesn't correlate to a particular Alzheimer's disease diagnosis, but it's definitely higher risk.
Yeah, I know that my because I suffered a stroke at the age of 26, my children, when they got pregnant, took a blood test to determine the risk of them if they had the gene to also have a stroke. And I think one did, one didn't. I forget what it was. But it's kind of the same benchmark, right? That you have the possibility, but you may not get it. You may get it. It may not affect you, right? The same as saying with the dementia. So it's very. I have a question though, because like all this research that you guys are so amazingly doing, where does it go after like you? Because I will tell you that all this wonderful research, is it used in another facet as well? I'll tell you why. My granddaughter has seizures, and they gave her a medicine that was a loss drug a long time ago.
Mhm.
So it's crossing over and using in another field for her seizures. Does your clinical trials go to like a bigger medical field that gathers all the information? I know that's probably a crazy question, but I'm just curious about it.
That's a great question. I honestly don't have a great answer for that. I'm not sure. It's a really good question. I know that I've overheard, and I recently took this clinical research course as well, and someone had mentioned that there was a drug for something else, intended for something else, but then it actually improved blood pressure. So then it was approved as a blood
Right.
pressure medication.
Right.
I don't know details about that, but that can be one example as to
Yeah.
why it's important for us to get all of the information.
Yes. Yes.
Because it can be indicative of improving something else and can
Yeah.
cross that. I don't know of anything offhand, but I know it's certainly a possibility, and that's why getting that information is important. And
Yeah,
in terms of, adverse events and how it affects the patient.
Yeah, especially, Ralph and I suffered a stroke, and since you're in the neurologist world talking
Mhm.
about brains, I mean, that's why we had you on the show, because
Mhm.
it's a branch, of what we do and what we're educating people on. And
Mhm.
dementia, like we said prior, it's sad, but at this point, there's no recovery for it, where when you have a stroke, at least you have the possibility of regaining some sort of, cognitive ability. Ralph and I are blessed because we could sit here and tell you that, but I know many other stroke patients that, have never gotten their speech back, never gotten their brain functions back. And it's like I said, it's a huge variety, and it's wonderful that you're doing the work you're doing. We're happy. Ralph, you have another question?
I got one more for you. I'm a big since my recovery was so difficult for so long, I had mental health issues. So I have one last question. What keeps you motivated and passionate, and how do you balance the emotional challenges of working with these patients?
Mhm.
That's a great question. I think it's intrinsic for me at this point. Like if I know, I kind of go where I'm passionate about, like where I don't know how else to explain it, but it's like, it's very intrinsic. I just go where my heart takes me. And being in the room with certain patients can touch me more than others, right?
Yeah.
So
Okay.
it's also managing myself and my reactions to these emotionally charging cases. I've also worked with those who have mental health illness or challenges as well, and helped them emotionally in terms of coping. So it can really be a bigger field, or this Alzheimer's disease can cross into mental health issues if not effectively managed, right? So that's why you're kind of caring for the patient and their family at once, and helping in that way. So for me, their emotional boundaries is something that I have learned as well, that I can only do so much given my scope and my role in this person's life. And they have a whole team that is also providing care for them. So I work within my role and understand and am aware that they have others kind of filling in those gaps where I cannot.
Yeah, that's an important thing about, because otherwise it'll affect you, and you won't be
Yeah.
able to do your job to the level that'll benefit anybody, right?
Absolutely.
Yeah, it's hard. It's really hard,
Yeah.
to do all
Because you
that.
you care for these people, and it's good. It's good to care. It's good to have a heart and be a human, but also at the end of the day, and I've had these conversations in the past, so that's why I know, and I've grown from them as well, just being a very early career individual. It can be emotionally charging sometimes. So it's just very important that we implement those skills as a staff member to kind of fill in a certain role within their life, and support accordingly wherever you can, just as you can, because I also have to take care of myself, and I learned that self-care is also crucial.
Yes. Well, your example, right? You have to take care of yourself.
Yes.
We all have to take care of ourselves, or those that can't take care of it need someone to be an advocate for them, but that advocacy needs to have a team, because they can't do it themselves. You have to form a team, which sorry, I got something in my throat. This show has, it's been on for 10 years. And one of the things we try to help people to understand is build that team around you before you need it. Build that team around you before you need it. Because when you need it, you may not be able to exactly form it the way that you desire. The people that are advocacies for you are not thinking along the path that you want it done. It's a hard conversation. I used to have a friend, Tracy, who used to run Grand Family Planning. You may have known her, Tracy Lawrence. She's a wonderful person. She passed on because of COVID, but she really taught us, that you have to build that team around you, so that you're ready, and they're hard conversations to have. But having the conversation does not mean that something tragic is going to happen to you. It just means that you're set up, you're prepared. Just like when you go to work and you set things up, or you're playing a softball game, you're practicing, you're preparing. You got to prepare your life for life, because you got to be ready for when the challenges come. It's really hard. It's really hard.
Yeah, beautifully said. And a support system is very important, especially in cases like this, because the disease is known to be, to decrease function and to get worse over time. So the more support that you can develop at any stage of your life, it's really important, the better outcome.
Do you find more and more use of CBT with these patients? Cognitive
behavioral therapy. Yeah, it's not to my knowledge with Alzheimer's disease patients, but in my experience, it has been more so with anxiety or depression. I've only had one client in the past that I have seen with both, with Alzheimer's disease and depression, and it can be difficult just depending on their severity of the cognitive impairment. So if someone is like more moderate or more severe, those CBT strategies during session won't stick, because they're having that issue with memory retention. So odds are after the session, they'll be like, what did we talk about? How can I implement that? So I have provided handouts in my experience working with this client. I also worked with the spouse as well to provide handouts that are specific to Alzheimer's disease and behavioral manifestations and compensatory strategies. How can we work around this? How can I manage the behavior to not irritate her even more and get her more agitated?
That's really interesting, because in life, when you go out, and you may have dementia, and someone, meets you for the first time, they might not understand what's going on personally in your life. And we say that because I hope that everybody has a little bit of empathy for people they meet, rather than judging people right away. You never know what's going on in somebody's life. They may be, out. You gotta go out in the world, but it's challenging. It's sad when people judge people and talk about people, especially with the internet and social media and stuff like that. It's sad. So I get what you're saying. It's very important to do that. Very important.
Yes. If I may add, it is particularly difficult around neurological compromise, because if you have a broken arm, we can see that there's a physical issue, right? We can see you in a cast. We'll help you accordingly. No problem. I'll go get that for you. But if it's mental health that we're talking about, because it can affect you mentally, of course, these ailments and neurological condition, we don't see that to the human eye. Yeah, we see it in neuroimaging. We can detect it via cognitive testing, but it's hard because we don't see this injury that is happening beneath the surface, and it can be difficult for folks to understand.
Yeah, when I was, first had my stroke, and I went right back into the mainstream because at 26, it was back 1889, so there was not the education that they have today.
Right.
So after a few months, I went right back into the mainstream of life, but I have found that when I got tired, what I realize now, when I got tired, people would be talking to me and I'd be looking at them like not understanding, not processing what they're saying. And they were looking at me like, what is wrong with you? And I didn't understand what was wrong with me. They didn't understand what was wrong with me. And the truth was, it was because I suffered a stroke. My brain was reformatting. It was reevaluating. I think you have 4 vessels in your brain, one of mine collapsed. So mine had to restructure and organize and go in different directions, but it did, but it was sad. So that's why I'm a very big advocate to have some compassion, have empathy for those that you don't know what's going on in their life. And please don't judge them. Just have a little bit of empathy for them. I think that's really important. We only have, it is. We only have 5 more minutes left. So I want to give everybody the opportunity to share the last words of wisdom as we were talking before. Sophia, go first. Wrap it up a little bit short about where we're going with this and the importance of your clinical work, and just whatever you feel is important to share with our audience.
Yeah, I think it's important for everyone to take care of themselves, right? We learned that self-care is really crucial, and to take care of yourselves via physical activity, these lifestyle factors that we can easily implement in our daily routine, things that we have control over, right? So that, I think, is a great theme just to go through life, not only brain health and putting off Alzheimer's disease, but also taking care of ourselves and filling up our own cup. So that's one. I do think it's promising that the brain is malleable in some capacity, as you can see with these stroke cases.
Malleable? What's malleable?
Malleable meaning it can restructure itself. It can work around these ailments.
Amazing.
As you can see in stroke as well, stroke recovery, the brain is amazing, right? There's so much more that we need to learn more about it. But I think clinical trials is one avenue that we can consider in terms of other treatment options in the near future, right? Our current treatment is limited, and education is still so much more to learn. So I think the more that we can learn about this disease, the more compassion that we can strengthen for others as well. So stay compassionate, stay curious is what I will leave you off with.
Thank you. It was
Awesome.
very educational for us today, and very hopeful for the future for everybody. You were wonderful. Ralph, you want to share your last words of wisdom?
Yeah, well, it's not words of wisdom. It's words of thank you, Sophia. Your commitment's extremely inspirational. I really appreciate what you've said today and what you're doing. And I really wish you the very best in your continued work.
Thank you so much. Appreciate you guys having me on.
Oh, anytime. And if anything new pops up or that's wonderful, please reach out to us. We'd love to have you on. We'd love to keep educating people, to let them know what's happening and the inspiration, and just got to keep people inspired. You got to keep people hopeful for the future. So thank you so much. I always blow kisses at the end of the show. If you feel comfortable, please do so. We want to thank everybody for joining us, especially Sophia and Ralph, my co-host, and Sophia. They were wonderful. It really was an educational show. And once again, we want to give our heartfelt condolences to Jim. And these 2 shows were for you, Jim. These 2 shows were for you. And we know that we'll make a difference in the world by sharing them with everybody. Have a wonderful Sunday. Hope everybody in New Jersey stays safe with the snow, and warm. And we'll see everybody next month. And on 3, I blow my kisses. 1, 2, 3. Bye, everybody. Looks wonderful.
Bye.
Bye.
Take care.
Bye. Thank you.
You're very welcome.
Yo no sé qué tú piensas. quejaré. Yo no sé lo que estoy perdiendo.